Symposium. Thank you for answering the poll questions. Sit back and relax as you begin to hear information from our impressive panel made up of COVID experts, a COVID survivor, and a vaccine trial participant. At this time, it's my great pleasure and honor to invite Monique Cephas, our esteemed president of the Baltimore County Alumni Chapter of Delta Sigma Theta, to bring the official greeting and welcome for our symposium.
Thank you, Pia, for that introduction, and good afternoon, everyone. Delta Sigma Theta Sorority Incorporated is an organization of college-educated women committed to the constructive development of its members and to the public service with a primary focus on the Black community. Delta Sigma Theta Sorority Incorporated is a private, not-for-profit organization whose purpose is to provide assistance and support through established programs in local communities throughout the world. Our major programs for the sorority are based upon the organization's 5-point programmatic thrust: economic development, educational development, international awareness and involvement, physical and mental health, awareness and involvement. The Baltimore County Alumni Chapter, also known as BCAC of Delta Sigma Theta Sorority Incorporated, has provided committed service to the Baltimore County area since its chartering on December 15, 1984. The mission of BCAC is to create strategic partnerships with nonprofit organizations, governmental and corporate entities, and build communities through our 5-point programmatic thrust and commitment to programs. BCAC actively serves the Baltimore County community, bridging many service gaps. Our physical and mental health committee. We accomplish this by connecting with the community, partnering with agencies and public offices to be responsive to our community's medical needs through means of advocating, educating, and promoting to support individuals with understanding and embracing a healthier way of life. We are here today to help undo COVID-19 confusion in the African American community, utilizing technology to extend our outreach across the United States. I hope you gain the knowledge you seek from today's symposium and walk away knowing the truths that are facing African Americans and equipped to make the right decisions for your lives. I would like to thank BCAC's Physical and Mental Health Committee for bringing this timely event to the forefront of the African American community. And thanks to our panelists and everyone who took time of your schedule to attend today's symposium. Now, I have the esteemed pleasure to introduce Dr. Sharita Golden, who will serve as our moderator for this afternoon. Dr. Golden is the Vice President, Chief Diversity Officer at Johns Hopkins Medicine and a member of the Baltimore County Alumni Chapter of Delta Sigma Theta Sorority Incorporated, where she serves as co-chair and Physical and Mental Health Committee.
All right, so thank you so much, President Cephas, for that warm introduction, and we're very grateful that you've decided to spend 2 hours of your Saturday morning with us. And when we started planning this symposium earlier this fall, we had no idea there would be so much active evolution of treatments and the vaccine around COVID. So we hope that this gives you the information that you need. So one of the things that I wanted to do before setting the occasion is just to sort of re-emphasize that you all come to us a fairly knowledgeable audience. So 77% of you know the signs and symptoms of COVID that should require an emergency room visit, which is very encouraging. We want to make sure the 23% of you who are not sure get that information by the end of this symposium. You all also know, 86% of you know why it's important for African Americans to participate in clinical trials around the vaccine. But I think quite disturbing is that 94% of you know someone who's either contracted and recovered from COVID or died from COVID. And I'm one of those people who knows someone in both of those categories. So we want to really sort of now set the occasion if we go to the next slide and just sort of reemphasize, why is it that we're here and why are we going to spend 2 hours talking about this on Saturday morning? So if I can have the next slide. So, it became very clear early on in the pandemic that COVID-19 was disproportionately impacting the Black community. And the Black community here is indicated by this green line, which is unfortunately been the highest when you look at death rates across the United States. And so we are dying at 3 times the rate of white Americans. And in fact, out of the almost 250,000 deaths from COVID that have occurred across the US, about a quarter of them have been in Blacks and African Americans, even though we only make up about 12 to 13% of the US population. So quite disproportionate. And in fact, if Blacks had been dying at the same rate as whites during this pandemic, there would be over 20,000 African Americans still alive. And that's a lot of our brothers and sisters. Next slide. So I think it's really important to set the tone as why is it that our community has been so at risk for devastating outcomes from COVID-19. And in fact, there have been a lot of structural processes in our healthcare system as well as in society that have really predisposed us to having a disproportionate burden of an impact of COVID. So, it goes all the way back to the historical discrimination and racism that occurred during slavery that extended even into the post-Civil War era. And so Dr. Marion Sims, who is considered the father of modern day gynecology, he repeatedly experimented and perfected his procedures on slave women without their consent and without anesthesia. And, in fact, that bias that, Black people have a higher pain tolerance is still a bias in our health system today, where it is not uncommon for African Americans not to have their pain controlled when they're in the hospital. And this really, was based on information that I think that, these physicians had to tell themselves really to justify what we consider today barbaric behavior. And then in addition, there was a eugenics theory that purported that certain race ethnic groups were inferior to others, and Blacks were among those groups. But we know today there is no scientific foundation for eugenics theory. But unfortunately, in the healthcare system, there are still healthcare providers who may think that minority patients are, less educated, less likely to understand their healthcare and recommendations, and also perhaps less likely to adhere to therapies. And then there was also the closure of medical schools that were training Black physicians back in 2010. Back in 1910 as a result of the Flexner report that basically said that we needed to move from medical school being proprietary training to it being based on the biomedical model. But what that meant is that a lot of medical schools closed across the US, but for medical schools that were training Black physicians, only 2 remained, and that was Howard and Meharry, at a time where African Americans could not gain access to predominantly white medical schools. So what this has resulted in now is that there's an overall decreased trust of our community in the healthcare system because of those practices of experimentation. And for those of us in Baltimore and at Johns Hopkins, we have wrestled with the legacy of Henrietta Lacks in that particular arena. There are language and communication barriers and the biases that I mentioned among providers that can result in a poor experience in the healthcare system. Next slide. And I think what's even more important, if we go back one more slide, to think about is it's not just the medical contributors, but there are also social conditions and policies that have resulted in structural racism that have impacted the health of our community. And so redlining and predatory lending practices that happened here in the Baltimore region, but in other cities throughout the US, once a neighborhood was redlined, then there was a lack of investment to maintain the public works in that neighborhood, lack of investment in education, and a lack of economic development in those areas. In addition, there was discrimination in federal housing loans that were refused to millions of not just Black Americans, but Asian, Hispanic, Jewish, and immigrant families. Next slide. And what's striking to me is that discrimination in federal housing loans was not officially outlawed until the year I was born. So it was when Lyndon B. Johnson signed the the 1968 Civil Rights Act into law. And so if we go to the next slide. So what this has resulted in then are neighborhoods where there is, in addition to poor housing, decreased cleanliness, decreased open spaces and sidewalks for physical activity, decreased access to healthy food. So people are living in food deserts and food swamps. Next slide. And the other thing specifically related to COVID is that many of our communities were more exposed to COVID because we were required to work in essential jobs during the pandemic where there was no option to work from home. There are also many who are living in crowded multi-generational living conditions. And then we know there's been a mass incarceration, particularly of African-American men. And if we think about this, the US represents 4% of the world's population, but we represent 21% of the world's incarcerated population. And that's a striking statistic. And so, you know, obviously in the jails, initially there was a lack of PPE for the prisoners and the workers. And there were poor sanitary conditions which led to rapid spread of COVID. And so all of that means is that many in our community working in the service sector, food services, medical assistance, environmental services have higher exposure to COVID. Next slide. And so really what has happened is that, you know, situations in our healthcare system, as well as our social conditions and policies, have put our community at risk for diseases like diabetes, heart disease, hypertension, and asthma. And so these are all conditions that if you have them and then you get COVID because you've been exposed, you have a likelihood of a poor outcome. So it's really important to think about this because it really implies like how should we be targeting policies. Next slide. So the purpose of this program then is really to increase your knowledge in what the contributors are to the COVID-19 disparities in the African-American community. And I hope the overview I just gave you helps you understand some of that, the signs and symptoms of COVID-19 and when to seek medical attention. The public health COVID-19 prevention and treatment strategies, both personal as well as community-based, and then progress on the COVID-19 vaccination and the importance of being updated on your influenza vaccine this year as well. And this has really been a moving target. In fact, late last night, the Pfizer vaccine was just approved for emergency use authorization by the FDA, and we'll talk about that during this panel. Next slide. So we have a really terrific panel. I'm so grateful that they're spending their Saturday with us. So Dr. Jadan Phillips is an associate professor of family, population, and preventive medicine at Renaissance School of Medicine at Stony Brook University. He also serves as medical director of the Stony Brook Health Outreach and Medical Education a program, which is a student-run outreach clinic. He also was recently appointed the Associate Dean for Minority Student Affairs. So we welcome him to the panel. I'll have him turn his video on. Next slide. We have Mr. Michael Green, who is a COVID-19 survivor and really has an incredible story to share with us. So we welcome him to the panel. And then we have Miss Maria Roach, who is a COVID-19 trial participant and also a documentary filmmaker and journalist. So we're grateful to hear her story and welcome her to the panel. Next slide. And we have Dr. Joshua Sharfstein, who's the Vice Dean for Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of Public Health, and also the former Secretary of the Maryland State Health Department and the former Baltimore City Health Commissioner. So we welcome Dr. Sharfstein to the panel. And then we have Dr. Crystal Watkins, who is a senior scientist and assistant professor at the Johns Hopkins Center for Health Security, and we welcome her to the panel. Next slide. And so what we really want to do in this program is really do a presentation of and recovery from COVID to really help you understand that. We want to talk about vaccine development and some of the concerns you have around Operation Warp Speed and what did that mean for vaccine development, the importance of our involvement in clinical trials, and also maintaining public health and preventive strategies. And one thing I just want to point out to everyone that I think is really important is that one of the leading scientists who's developed the technology that's been used to make the development of this vaccine possible is Dr. Kizzmekia Corbett, who is actually the lead of the coronavirus and immunopathogenesis team at the NIH Vaccine Research Center. And so, one of our own has been involved in the development. So with that, we will transition to our panel. And thank you all again for joining and spending time this morning. So I want to start with with Dr. Phillips, and I know that you have been very involved in the clinical care of patients with COVID-19. And so can you tell us what are the signs and symptoms of COVID-19 that you've seen in your patients, and what are those signs and symptoms that should prompt enough concern to seek medical attention?
Well, good day, and again, very humbled and honored to be part of this group to provide this very important information. Again, COVID is something that can present in a variety of ways. I am in New York, and one of the things that I always say is if you think you have COVID, then act like you have COVID. So that means that if you think you were exposed, if you think that someone around you that was close to you was sick, then you need to take precautions from that moment. As far as signs and symptoms, the most common symptom you could see is no symptom at all, which poses a significant danger of it because of the high infectious rate. But in addition to that, you can see upper respiratory symptoms. So again, if you're a person that has allergy symptoms, it is something that you want to, stay on top of, because again, if you have Mondawmin mole, it's probably not the cool thing to start sneezing, because again, you might be looked upon in a way. So again, you can have symptoms that you might notice with a virus as far as body aches, fever, chills. In addition to that, you can also have gastrointestinal symptoms like abdominal pain and diarrhea. But more specifically, one of the things you can notice with COVID, which is a little different, is you will notice a change in your taste and smell, and you can also have some significant GI symptoms and even a rash. As far as symptoms that we should watch out for when it's time to consider more aggressive or more significant medical intervention, if you start noticing that you're having significant chest pain, if you start noticing some significant shortness of breath, or if you notice that your person around you has had a change in their, the way that they're thinking is just off today. I'm really confused, and this is not something that I'm accustomed to. If I'm very tired all the time, that can be a concerning sign. If you notice that their fingertips or their lips are blue, which can be a sign that they're not adequately getting oxygen, can also be a sign that they should be seeking more emergent attention. In addition to that, there also has been a situation with individuals that have gotten through COVID that they still have some residual symptoms. They're being referred to as the long haulers. Now, one of the interesting things with COVID that we'll find out as we go through this is there's still a lot we don't know about it. So these long haulers are individuals that are having residual symptoms. And these residual symptoms can be things like confusion. Individuals notice shortness of breath that lingers. In addition to that, individuals may notice moments when they start sweating profusely, having some rapid heart rate, or body aches can even happen, and even fatigue. So I know in New York, it's a new activity. We've been opening up. There's only 2 in the area right now. They're called post-COVID clinics, and they're clinics that are designated at looking at how can we optimize or improve the care of people with COVID, especially those that are having lingering symptoms. Because again, you can get through this and you think you're over with it, and then it lingers. I have my sister, who is a Harvard Business School grad, has a classmate who graduated with her from Harvard Business School, who feels that she is still not on top of her mental game to do her job that she went to school for, even 6 months after contracting the virus. So again, those are some things that I think are very important for us to keep in mind, which is you can be asymptomatic, and the asymptomatic people, even though you don't get very sick, you still have to be concerned because you can spread it to those that you love and care about. And then we also have to be mindful of transitions in our condition that may start us in some of the symptoms that I mentioned before, as far as respiratory changes in your mentation, and also signs that you might be not having adequate oxygen.
So thank you so much. That is such a great overview. And I should just say that we're almost welcoming Dr. Phillips back home because he went to Johns Hopkins undergrad and went to University of Maryland Medical School. And so we're grateful to have you back here talking to the Baltimore community. So one question we've also been asked, and thank you for sort of describing that post-COVID syndrome and these other effects. And we're going to talk to our COVID, someone who's had COVID who can elaborate on that a bit more. But can children be infected with COVID-19, and are their symptoms similar or different to adults?
Well, children tend to be the ones who are the asymptomatic ones. That's why even though, children don't get very sick, we still have to be very mindful of protective measures and being aware of them because they can spread the virus. So again, if you're accustomed to my kids stay with my mother some days or something along those lines, I think it's very important for us to recognize that children can participate as far as spreading this. The additional thing is there've been cases, and these are children that have significant health issues, that they can develop problems with their coagulation system. In addition to that, they can also have some serious clotting type disorders that can occur. So again, children too can be very sick or very ill from this virus, and we don't need to take just because they, in most cases, won't get very sick. We should still take what's going on with them very seriously.
Thank you. That's so crucial, so they can be a vector. That's important for us to recognize. So thank you. So I'm now going to invite to the panel Ms. Robin Huger, who is going to introduce Mike Green to us a little bit more personally.
Good morning, Michael Green.
Good afternoon.
Good afternoon. So as I call you Mike, good to see you. So one of the factors of inviting you to this platform this morning is to give us our viewers a real life human feel to what it looks like to experience and survive the coronavirus. And if I can speak candidly for a second, through my lenses about that day in March, scrolling down my Facebook page, there you were in the hospital bed as the virus had sort of hit the public newly, completely distorted and shocked. There I was looking at my classmate, a friend of 30 years, literally fighting for his life and grasping for air. You courageously, and I say that very passionately, you courageously sorted It Not Robbery to share with us on a video in hopes to inform and educate us of this deadly disease. So Mike, if you would share with us the days leading up to being hospitalized and diagnosed of COVID-19. When did you know you were critically ill? Mike, if you could walk us through day one, please.
Yes, thank you, Robin. And I want to say thank you to the women of Delta Sigma Theta for allowing me to share my story of COVID-19. My journey started back in the beginning of March. I started off with a simple mild cough. And as the week progressed, it had gotten worse. I started to have a fever. I started running a fever. Then the cough became more intense. And from there, I took myself to my primary care doctor. And from doing multiple testing for the flu, pneumonia, bronchitis, those tests came back negative, and my doctor called the health department, and the health department sent EMS to his office, and they took me to the hospital. At that time, I didn't know that I contracted the virus. I didn't know what the road to recovery would be. There was not a lot of information on how the virus was affecting everyone, let alone the Black community. I decided to share my story while I was in the hospital. I saw many people on social media that looked like me say it wouldn't affect me. My 7 days in the hospital consisted of being on the brink of kidney failure, high fevers, seizure-like coughing, and extreme body aches and fatigue. Rapid heart rates and high blood pressure and severe chest pains came as the virus attacked me on the 5th day. The doctors had no clue what drugs to use, so it was more of a throw it at the wall approach and see what would stick. My recovery has been just as hard. I've been diagnosed with an autoimmune disorder, which include symptoms of COVID fog, fatigue, shortness of breath while walking just a simple block, and intense sweating, as Dr. Jadan had mentioned earlier, severe tingling in my arms, legs, face, and tongue, and a intense stabbing pain near the left side of my heart. In the evenings, I also suffer from PTSD. I have donated plasma as I still have tremendous amount of antibodies. I have also found the research program here in New York at Mount Sinai Hospital. They provided me with great information and treatment thus far in helping me continue to fight this battle with COVID-19. I thank you for allowing me to share my story today, and I look forward to some questions.
Thank you so much, Mike, for sharing your story and being so transparent, because everyone's not completely comfortable, talking about their experience. And I think you sort of answered this, but why was it important to you to share your story back in March? And you've continued to do that. You shared it recently on one of our local news stations. So why is that so important to you to share?
The reason why I shared it was because back then it wasn't a lot of people in the Black community who were being shown as catching the virus at that time. Okay. So a lot of people, especially on social media, they were all saying the same thing. Well, I'm just going to go out and still live my life. It's not going to affect me. It's not attacking people that look like me. So my family didn't want me to go public with it, but when you're in the hospital, isolated from the world, you only have your thoughts. And it just got to me at one point, and I just said, I have to share this story with people so that they know that it can affect you, because I am affected. Right.
No, and we thank you for that, because I do remember hearing people early on thinking it wasn't affecting our community. And I can tell you, for those of us on the inside of hospitals taking care of patients, and as you look at those and think about those statistics I shared earlier, it clearly is impacting our community, and that became clear very quickly. So thank you so much for sharing your story.
Thank you.
So we now want to talk to Dr. Joshua Sharfstein, if we have him turn on his camera and mic, about everything that's currently evolving with our coronavirus vaccine. And as I mentioned, last night, I think I was almost falling asleep on the sofa when I got the Twitter link and the Washington Post link saying that the FDA had, given the first emergency use authorization for the first vaccine. So Dr. Sharfstein, could you explain to us what an emergency use authorization is, and why is it being used for the COVID vaccines at this time?
Sure, and thanks so much for having me, Dr. Golden, participate. I think, the FDA got this done just in time for this session. That was what I thought when I saw the news from last night. So an emergency use authorization is a special power that FDA has to make different kinds of products, tests, medications, and vaccines available to the public in the setting of an emergency. So it can be done as appropriately, quickly, in order to be able to help people either be treated or be prevented from getting sick, like through the vaccine. In this case, the FDA had to decide what was the right amount of data, both on efficacy, the effectiveness of the vaccine, and on safety, to feel comfortable providing a vaccine to the public. And the agency wrote that down in a document that was widely publicized. There were actually some objections from the White House, but the FDA stuck to it anyway and said that in order to be worth it to take, and even in an emergency, it had to be at least 50% effective, and there needed to be at least 2 solid months of detailed safety data in order to begin to make it available. Having said that, the FDA will then continue to collect all kinds of data, both on the effectiveness and safety, and the vaccine is expected to get fully approved in around April of next year. So the idea is that while it might not have as much follow-up as a full approval, if it's really looking good, people can start to take it in the meantime based on the balance of data about effectiveness and safety. And sure enough, this vaccine showed not just 50% effective or 60 or 70 or 80 or 90, but 95% effective. So that was extremely good news. And the safety data to date is also very, very strong. And the trials were very diverse in many ways: age, race, ethnicity, gender, and they didn't see any particular issues with safety other than that younger people had some more annoying side effects in the first 2 days than people who are older. And those were like their arm was sore or got red, or they got a fever, or maybe they had some joint pain, but those went away after a couple of days. So very strong on safety, extremely good evidence on effectiveness. And on that basis, FDA went to the advisory committee. We're the only country that did this. You know, other people said, you know, President Trump was complaining, how come we're taking so long? Well, the United States went and convened independent experts to look at the data. The United States reviewed all the data again from the drug companies, didn't take their word from Pfizer, didn't take the company's word for it. And the advisory committee overwhelmingly voted that this was the right thing to do. And so the FDA went ahead and did it last night.
So, right, so I think there are some very important points in what you said. And so, and a lot of that is that the process and that rigor was still a part of even the emergency use authorization, you know, component of this, because that's one of the concerns that we've heard. You know, the other concern that we've heard is that, you know, that there's such rapid vaccine development, you know, using a new technology, and that everything's been politicized and people were concerned. And so you actually sort of talked about how, you know, the FDA used its own process that it always uses, independent of what they were being maybe asked to do by the executive branch. So, you know, what would you say to people that have concerns about how rapidly everything happened? Like the name Operation
Sure.
Warp Speed has given people pause. What is Operation Warp Speed, and why was that needed here?
Yeah, I mean, and it's pretty clear this happened much faster than the development of other vaccines. So how did it happen so fast? One of the reasons is they were able to use a system that is already under development for other types of vaccines, and that's this mRNA system. But the other reason was that the government spent a lot of money to make sure that everything got started as quick as possible. So ordinarily what happens with a vaccine is first you do the phase 1 study, if you're a company, and you see how that goes. And if that doesn't go well, you don't spend for the phase 2 study. You just do the phase 1 study. In this case, they started the phase 1 and they were already spending to start the phase 2 if the phase 1 worked. And if the phase 1 didn't work, well, then they would have spent all of this money, taxpayer money, but you know, no problem. Nobody would have ever gotten it as part of phase 2. I'm simplifying a little bit, but the idea is they started everything at the beginning, realizing that if at any point the data wasn't good, they would just lose whatever work they'd done on the subsequent phases. In fact, they went so far as to start manufacturing the vaccine even before they got the study results. And if the study results were poor, they'd just toss it into the ocean. You know, they weren't going to use that vaccine. That's what made it fast, but it wasn't that each stage wasn't fully studied. That's the important thing. They compressed the timetable by getting rid of those pauses where a company would wait to see whether to reinvest. And they just said, look, we're going to give you the money, invest in that next step. And if it doesn't work, then, you know, the government's out some money. But if it does work, we won't be sitting around waiting. And that's how they got it faster. Now, an example of this point is really important. 46,000 people were in this study. That is a full study. That is the same size of a study that would be done under any circumstances for a vaccine. You really can't do bigger studies than that. You know, 25,000 people or so got the vaccine. The other half got the placebo. It's a huge database that they're then able to use to assess whether it works, whether it's safe. And that was the usual thing. So it, you know, in a different universe, maybe the FDA wouldn't have done that. In fact, other countries have said, let's not do the full study that we usually do. We don't have the time. The FDA said, we want the full study. We want at least a 50% decline in death, and we want at least 2 months of safety data. And when the White House pushed back on that, the FDA held firm. And that's why we had such a robust set of data that was discussed, and why the independent experts felt so comfortable moving forward. But, you know, I do think it's important for people to understand that this isn't the end. There's so much more data to be collected. The data that we have is very strong. It's worth it to make it available to people, but we're going to learn more and more about it. We're going to see how effective it is under real world conditions. We're going to see if there are other you know, adverse effects that can pop up, and we'll learn about those. But for where, you know, it is that's what we do for every vaccine. Every vaccine starts at a certain point, and you learn more while it's in practice. And we're going to do that here, but we're talking about a disease that is killing now more than 3,000 Americans every single day. And to have one that has this strong evidence of effectiveness and such a strong safety profile so far is really a great thing for where we are at the moment.
No, I think that's really important to understand that process. And just to point out that the trials were large. It only takes years to recruit. But again, because of that financial investment, you could recruit those 46,000 people. So at least the two vaccines that are at the FDA currently, the Pfizer and the Moderna vaccine, each of those people have asked, a question I've gotten a lot is, you know, how many were African American? So they were about 10% in each trial. So, you know, about 4,000 in one and 3,000 in the other. And I think almost all of them were recruited from the United States. So, you know, there was representation in those trials, and also older individuals, Latino individuals.
And they talked about that both in the FDA documents and in the meeting yesterday, that they did not see worse side effects among African Americans, particularly. There was no difference in how effective the vaccine was by race or ethnicity. So it was a very strong findings for both of those things. So it really, the decision is very similar depending for anyone, depending on, irrespective of their race and ethnicity, from a safety and effectiveness point of view.
Well, I know we have Maria Roach, who's actually a vaccine trial participant, and we want to invite her to the panel. And Dr. Sharfstein, do you want to sort of engage her and so she could share her experience with us?
Well, first of all, thank you so much, Maria, for becoming a trial participant. Let me just start by asking you why you wanted to do that.
Well, thank you. Thank you, Dr. Sharfstein. And thank you so much to Delta Sigma Theta Alumni Chapter of Baltimore County. I am a Maryland girl making do in Florida the best that I can, and masking up and staying safe. And the reason why I decided to do this is earlier this summer, I was producing on a CNN BBC documentary chronicling the race to a vaccine, looking at 5 continents, the manufacturers, the researchers, and in that opportunity, I did a lot of research. And what I learned is that, as you just shared, Black participation was quite low. As a 12-year breast cancer survivor, I have seen the benefit of medical research. My father is a prostate cancer survivor and was treated there in Baltimore, part of a research trial. And he's now 91 and he's on this Zoom call. And my sister, my twin sister, who I lost to breast cancer, we had 16 years with her, and that was thanks to research. And so I realized that I needed to pay it forward. 12 years cancer-free was on the support and the foundation of really amazing research. And so with that in mind, I started to do some research of my own. And I found that, yes.
Oh, I was going to say, so how did you find the trial that you participated in?
I went to the US government's CoVPN website, and that is the COVID-19 Volunteer Participation Network. And I found the 2 trials here in Orlando. One was a Moderna trial. I did go and have a visit, and I met the nurse, a Black woman, which was very important to me. And then I went to the other trial, and I saw that the medical director and the research director were people of color. This was for the Oxford AstraZeneca trial. And I chose that trial because Oxford AstraZeneca really had a commitment to making a vaccine that would be affordable. And for me, that was the key, that I didn't want to be in a trial that not everyone who looked like me could get. And so I received my first shot on September 3rd. and the booster shot on November 13th.
Got it. And how did you feel after the shots?
I felt 2 hours after getting the shot on September 3rd, like I'd been hit by a truck. And it was akin to the flu shot that I get every year. And I actually did a little happy dance because then I realized I got the vaccine. And it's a double-blind study. I had a 66% chance of getting the shot. Some trials are 50-50. This was a 2-to-1. So I was quite pleased. I really wanted to get the vaccine, and I've been chronicling it, filming it. I'm a documentary filmmaker because I think a lot of the issues is demystifying the process.
Right.
For,
oh, go ahead. Please finish.
as Dr. Golden put it so beautifully at the beginning of this program, Black Americans have a lot of reason to fear the medical process. We have been undervalued, we have received inadequate care, and there's just a lot of history. So we need to have more of these symposiums to talk about the realities, but we also need Black participation and research.
Very well put. And I would also point out, you're making a really important point about those initial symptoms that people do get, sometimes don't feel well for a day or two, but that's kind of a sign that the immune system is kicking in.
Yes, exactly right. Yes.
So for you, you weren't like, I can't believe I signed up for this study because now I'm feeling bad for a day. You were like, okay, I got the actual vaccine, and this is a sign that I'm probably going to be protected from coronavirus.
Exactly. I never took my mask off, but it did make me feel a little more comfortable navigating outside of my house. My family were here in Orlando, Florida, and we really did hunker down. I have teenagers. I have my father in his 90s. I have people that I need to protect. So I didn't have this sense of, I'm immune. I never took that for granted, but it certainly let me sleep a little more peacefully at night. And that's been something that I've been excited to share, as I have many friends who are doctors and nurses, and they are looking at getting the vaccine next week. And they've been pinging me, asking me, well, what do you think? And I said, COVID-19 is no joke, as we all have been talking about, as Mike shared so beautifully. And thank you, Mike, for sharing your story. It is really scary. The peace of mind that you get for a vaccine is money can't buy that peace of mind. I think stress is something that we don't talk enough about, and the toll that it's taking on all of us is something that I think we should stop and really think about the vaccine.
Well, thank you, Maria, for sharing that, because I think it's important. I mean, there are some unknowns here. So we don't know the long-term effects of the vaccine, but we also don't know the long-term effects of COVID. So those are the things you have to really be thinking about. And we're sort of beginning to understand, like as Mike had pointed out, and what Dr. Phillips had pointed out, what some of those long-term consequences might be. So something really important to factor into your thinking and decision making.
And if I could jump in for just 1 second, Dr. Golden, it is true that the vaccinations have only been happening for a few months. So of course you don't know beyond that exactly what's going to happen. For the mRNA vaccines, there are people who have gotten those vaccines for other conditions for years. And there's a lot of follow-up that they have without any problem. And there is the biological understanding of the vaccine, which is that they're giving mRNA that really degrades very quickly. So it's really believed that there's not a long-standing change to the body from the vaccine. It really is temporary and boosts the immune response, similar to the adenovirus vaccine, and that is the AstraZeneca Oxford vaccine that Maria took as part of the trial. So while it's absolutely true we need to get more data on safety, it's not exactly true that we have no idea what's going to happen. We have a lot of idea from the science and from some experience. And personally, it would be a no-brainer. I would much rather have to worry about the uncertainty of what might happen after a vaccine that appears very safe than after a viral infection, where we know there's so many people experiencing those long-term effects that we were hearing before from the doctor.
And if I could leave with our audience, I feel great. And that's something that is something to celebrate in 2020. As Dr. Sharfstein just shared, there are so many unknowns with COVID-19. I have to tell you, as a almost 55-year-old woman, the care that I received from the immunology clinic, it's a clinical trial, has been some of the best care that I could ever imagine having. I have the nurse's cell phone number. I have the doctor's cell phone number. If I ever feel anything, a scratchy throat, I can call them, email them, text them anytime. I would say to someone who's considering, like, is a trial right for me? The care that goes into it, you really truly feel like a hero. Like, we're really doing this because lives are at stake, and everyone, the clinicians all know that. And that's something that is really makes the experience worthwhile, that we all know how important this is.
Where is your documentary? Are you posting about your experiences now, or it'll come out later?
I'll start doing both. So pretty soon you'll start seeing some clips about the story. I have lots of video, and I have done daily journals. And so the day that I received it and I felt like a truck hit me, you see me looking like a truck hit me. I will start rolling that out. I would share that if anyone wants to follow me on my Instagram, it's at Maria Luisa Lives, and I'll start rolling out some of the clips on that soon.
Yeah, that will be terrific to share. And thank you so much for your participation and, for sharing your experience, because I think for many of us, we haven't had a chance to talk to someone who actually has participated in a study. So that is extremely valuable.
Thanks, Dr. Golden.
And I know one of the things that motivated Maria is that around the costs and the access. And so I think that's one of the last questions I want to ask Dr. Sharfstein about in relation to sort of there's having an effective vaccine, and then there's also then how do we make sure it's accessible to everyone? What is the cost structure anticipated to be? That's been a question that's come up a lot as well.
So for the United States, all of the vaccines will be made available without charge for the vaccine. And that's through Operation Warp Speed, where they're just buying all the vaccine. So no one should be charged for the vaccine. What's left to be worked out and is the charge for getting the vaccine. So if there's a public health clinic, nobody's going to charge you. But what if you show up at the pharmacy? What if you show up at your doctor's? Could you be charged just for the administration of the vaccine? And I think there's a lot of policy efforts to make sure that people aren't charged for that. So there's no cost anywhere. But the vaccine itself will be free in the United States. I think the point that Maria may have been making about why she was particularly appreciative of the Oxford vaccine has to do with the global market. Because it's my understanding that Oxford AstraZeneca has made some commitments globally that maybe some of the other countries haven't, and trying to make the vaccine available globally. I think, the full story about what's going to happen globally is going to evolve very quickly over the next few months.
All right, well, great. Well, thank you for sharing your expertise with us. And I'm sure during the Q&A, there may be some more questions around this. So thank you. So next I want to switch to our last panelist, Dr. Crystal Watson, to really think more about our public health practices and approaches around the vaccine. So I'll have her turn her video on and unmute. But so thank you again for your time. And can you discuss what the currently suggested public health practices are? So, a lot of people are feeling this pandemic fatigue. What is that, and how can we avoid becoming fatigued? And what's the danger of becoming fatigued at this point?
Yeah, thank you so much, Dr. Golden. Thanks for the opportunity to meet with your incredible organization and talk with you all today about these important public health measures. Let me first start by giving a little bit of information about where we are with the pandemic right now, because this informs what public health measures we need to take. So right now we are having more cases in our communities than we've seen at any other point during the pandemic, basically. So that means for all of us that by chance, we're just much more likely to come into contact with someone who's infected with this virus, just in our everyday lives. And so we're also seeing significant increases in hospitalizations and deaths around basically the entire country. And in some places, hospitals are becoming so stressed that they're being overwhelmed and are not functioning the way they should. So even with the great news of this highly effective and safe vaccine on the horizon for us, we still have to get through this current surge that we're experiencing over the winter. before we can let down our guards. So the public health measures that we've all become very accustomed to over the last 9 months or so are really what we need to double down on now. And first, I just want to emphasize that we need to avoid indoor gatherings as much as possible. This is my first and I think most important piece of advice here. We know that there are indoor spaces where transmission happens much more readily. So as much as we can avoid those, it will protect us a lot more. This is especially true in places where there's crowding and poor ventilation. So we should keep trying to avoid those spaces and support our communities by doing takeout in restaurants and shopping online and doing those things that are safer but can still support our economy. Second, we need to take steps to continue to keep physically distant as much as we can when we're together with people outside of our households, and especially also wearing masks in those situations. We have even more data to show now that masks protect both you as the wearer and the people around us. So this is so important for us to continue to do. A good cloth face mask, which is what most of us are using, is one that fits very snugly around your face, but has space for your mouth and nose so you can breathe fairly easily, and has 2 or 3 layers of tightly woven fabric like cotton. The third thing I would say would be that we should be helping out our communities by participating in public health efforts to control the spread of the virus, and particularly contact tracing. So if a contact tracer calls you, I really urge you to pick up the phone, have a conversation with them. They're working so hard to help people take precautions so they don't spread this virus, specifically quarantining at home. And I know that's a big ask for many people, especially those who have hourly positions and have a hard time quarantining. But the health department, the good news is the health department has resources to offer, so can help people quarantine safely outside of their homes if they have vulnerable members who live with them, can make food or medicine available to people, and even in some cases provide replacement income if you have to take time away from work. So those are the big public health measures that are in place right now that we should still just continue to focus on.
That's extremely, extremely helpful. I've been joking with everyone that Christmas gifts this year should be decorative masks and get them in every color so that we can get safely through the winter. So then what about current testing options for COVID-19? You know, what are the current options for testing now? And, you know, for people that maybe think they've been exposed or they're having symptoms and they just want to be certain.
Yeah, so tests are particularly relevant for people if you're having COVID-like symptoms, but also if you've had a known significant exposure, and the CDC defines that as within 6 feet of someone who's positive for COVID-19 for a cumulative total of 15 minutes or more over 24 hours. So those are the people who should primarily be seeking the test. We do have so many cases right now. There's also testing of asymptomatic people who haven't had exposure if you need to go out and be more sure that you're not infected. But right now our systems are so stressed, I would maintain testing mostly for people who have symptoms or an exposure. I know Baltimore City in particular has a range of testing sites that you can Google where to get tested in Baltimore and it'll come up. The convention center in the city is one site where individuals can get tested. I know at Johns Hopkins, there's a number of sites, and if patients don't have a primary care provider, that's not a problem. They can just call the number on the website to get access to testing. Other health systems in the city also have this as well. And we all know that COVID-19 symptoms and flu symptoms can look quite similar, especially early on in infection. So now there are some testing sites that can use a multiplex test to look for both flu and COVID. Fortunately, we haven't seen as much flu circulating in our communities so far this year because I think of all the measures that we're all taking to try and prevent COVID transmission. So that's the good news.
All right, no, that's very helpful. And there's also, I think the Baltimore County website has something similar where you can find out where, you know, in the state you know, in the county, or if you're outside of Baltimore County and Baltimore City, you know, where else in the state of Maryland, or if you're outside of Maryland, where in your state, in your local jurisdiction that testing is available. So that's extremely helpful. So I just want to, a couple of things for the audience before I ask Dr. Watson a couple of more questions is that we are going to open up the chat so that you can start asking your questions for the upcoming Q&A session. So just wanted to make you aware of that. And I also understand from one of our technology committee members who are in the background making all of this run beautifully, that she has a friend who's in the audience today whose brother just received his Pfizer vaccine in England. Either yesterday or today. So, and in England, they started earlier this week with their vaccination. I think Canada will be right behind. So just wanted to share that. So one of the last questions I have for you, Dr. Watson, you know, is around the gatherings. And so, you know, we had a Thanksgiving holiday. The Centers for Disease Control and Prevention, you know, recommended that people not travel, that you just have Thanksgiving with your household contacts. And so normally my mother-in-law and I cook for a lot of people. And my parents are here, and we have all of these folks over. And I cooked for 3 people this year, my husband, my son, and myself. And so we have the Christmas holidays coming up and our other winter holidays. So can you really talk about what we've learned from the Thanksgiving season and how that's impacted what we're seeing with COVID? And then is there a safe way to gather with family and friends for Christmas and the New Year's holidays?
Yeah, that's a great question. So right now, I think we're seeing in the case numbers a spike in cases from people who traveled and gathered over Thanksgiving in spite of the CDC's recommendations. Unfortunately for all of us, gathering for the holidays is really coinciding with this worst point in the pandemic so far. So we're so worried in particular about people unknowingly bringing this infection back to their older relatives who may have been very careful to stay safe up to this point. And we know how much more vulnerable older individuals are. So my husband and I was really wanting to gather with my in-laws over Thanksgiving. My son, who's turning 2 years old, his birthday is on Christmas. And so it's heartbreaking. I have to say I shed a few tears about not being able to do it, but we've made the decision personally that it's just too important to us to keep our family safe. We want to be able to spend many more Christmases with them. And so we're going to celebrate on our own, like you are, Dr. Golden, and try to keep our parents safe. But I know that not everyone can do that, and other people make different choices. So if you are going to see people outside of your family, your kind of household family for Christmas, I think there are some steps you can take to be more safe. Ideally, you would want to quarantine beforehand, and the CDC just actually changed their quarantine recommendations to be a 10-day quarantine rather than 14 days, which we've been hearing about since the beginning of the pandemic. So trying to stay quarantined, really avoiding those other contacts in our community for 10 days. And the other option is you could quarantine for 7 days and then receive a negative test. This doesn't eliminate the risk entirely. There will be some risk of getting together still, but it can give you more certainty that you're not carrying the virus back to your friends and loved ones. So that's one measure you can take. Also, if you can have gatherings outdoors, stay masked up, stay physically distant, even when you're together, all of those things can reduce the risk.
No, thank you. That's very helpful. We ended up having our Thanksgiving 2 weeks later than Thanksgiving because my son had to fly home on a plane from college. And then even with that, we did it last weekend, but my parents who are in their mid-80s ate in one part of the house and we ate in a different part. So there are some things that you can do to be safe. So I want to thank all the panelists for sharing, and I'm going to ask if they could all turn their cameras back on, and we will move to the Q&A. And we have some questions in the chat, and okay, so, and I'm going to be reading some of these from my email. So I'm working on 2 devices. So thank you for your patience. So here's one question is, will the vaccine need to be administered yearly like the flu vaccine? And do we have enough information yet to know that? So Dr. Sharfstein, we would love to toss that to you.
Yeah, the answer is we don't know. One of the things that'll be studied is how long immunity lasts to the vaccine. There's some evidence to believe that actually getting the vaccine leads to a stronger immunity than getting the illness for at least a bunch of patients, maybe not everyone, but for a bunch of patients, because the response is so strong in the immune system to the vaccine. I've heard, some people who know a lot about vaccines say they think that if it is necessary, it will be probably more than a year, maybe like every other year, every third year, something like that. But we really just don't know yet.
Right. Okay. Terrific. And then which vaccine is most effective? There have been several people that have asked this question. There are three. So there's Pfizer versus Moderna versus AstraZeneca. So, how can people sort of make decisions about which one is the right one for them?
Well, so I personally wait to see what the FDA thinks about the company's data, because the FDA reviews that data from the raw data files and gives its perspective on both effectiveness and safety. And so the FDA found, very high effectiveness for the Pfizer vaccine, and we'll see the FDA's review of Moderna. From what, I imagine it'll show based on what the company has said, it's probably going to be equivalent. It's going to be very hard to tell the difference, but we'll see. That just like they looked in different groups, like different racial and ethnic groups, to see if there are any differences, they'll do that in the Moderna vaccine too. The AstraZeneca is not going to be available for a little bit longer in the United States, if at all. We'll see what the results of those studies are, and then they'll be reviewed, and FDA will do its own assessment. So it's a really good question, but we won't know until we really see the FDA's assessment of each vaccine.
Right, that's very helpful. And then the question is, how does the vaccine work for people who could potentially be asymptomatic? So in other words, if you have an asymptomatic COVID infection, what's recommended from a vaccine standpoint?
So the vaccine studies were looking to see if people got sick with COVID-19. That was the main outcome. The 95% reduction was a reduction in illness among the people who got the vaccine. So another really interesting question is, well, whether does it keep you from getting infected at all, even with an asymptomatic infection? And the company said it's going to be doing more studies of people in the big vaccine study, more research to find out the answer to that question. But right now it is really not known yet. But that's a good example of something that we'll find out. We're going to find out how long immunity lasts. We're going to find out, the benefit for asymptomatic infection. It's likely there's some, but how much, we'll find out.
Okay, no, that's very helpful. And there's a question sort of related. Does the vaccine prevent you from contracting COVID, or does it minimize the symptoms that you could get?
Well, it definitely reduces people from getting sick from COVID, 95% in the studies that were done. But whether it keeps you from getting infected with the virus at all, that's what this next set of studies is gonna show.
All right, great. And then, and I can answer this question, is if you're asymptomatic, does that mean you have to wear a mask indefinitely? And so, if you're asymptomatic, you have an asymptomatic infection and you're in the house, for example, you want to wear a mask. I don't know now if it's up 10 to 14 days. It keeps evolving. Maybe Dr. Sharfstein or Dr. Watson can clarify, but you would be wearing a mask to prevent that spread during the time that you're infected. But even after you've recovered from your COVID infection, all of us still need to be wearing a mask, is my understanding. Is that right, Dr. Sharfstein?
Right now, we're wearing masks. And the reason we're wearing masks is that we have a lot of infections out there. And so it's both to prevent the chance of you giving it to someone else or you getting it again. Interestingly, in this study, I found this a very interesting little point. They allowed people into the study who had evidence that they previously had been sick with COVID. Okay. And some of those people were in the placebo group, so they never got the vaccine. And not an insignificant number of them got sick again. So it's pretty clear that people who get a mild infection, for example, and they don't have a big immune response, are susceptible to getting it again. It's not everybody, but a bunch of people did. The vaccine actually helped, it looked like, to the FDA, although there wasn't enough people to make a definitive determination. So that's why they're really, recommending vaccination for people who may have been sick before, because they could still get sick again. And they think the vaccine is going to be helpful to them based on the results of the study.
Right, terrific. That actually answers one question that's come up. I know a lot of people have asked that question. Let me just look here. Okay, so this is a question, and this is a good one because we know that with the vaccine administration that started in England this week, that a couple of people had allergic reactions. So it says, should those of us with food or respiratory allergies feel comfortable in taking the vaccine?
So that's another area where there's going to be more data. Right
More
now,
data.
I think the agency is not recommending the vaccine for people who have a history of severe reactions to vaccines, because individuals in that category were excluded from the study. They're looking in depth at the cases in the United Kingdom, and I'm sure there are going to be more recommendations. At the meeting, there was discussion of, just to put everyone's mind at ease, do a special study of people with food allergies, but there's no real reason to believe people with, modest food allergies are at particularly high risk for, adverse reactions to different kinds of vaccines. Although there are some vaccines if you have an egg allergy, but that's not going to be the case for this vaccine because it's not made in eggs. So I think we'll get more information about that. Probably by the time the vaccine comes around, there'll be more information. For every single vaccine, you have to have an EpiPen nearby. And so whoever's giving the vaccine should have the EpiPen. There's always a tiny, tiny risk of a severe allergic reaction. That's one of the risks of vaccines. And so, it's going to be important for that to be followed here. And as we learn more, that information will then make it into practice. But right now, the main contraindication, the main reason not to get the vaccine would be is if you've had a life-threatening allergic reaction to a previous vaccine of any kind.
Right. So that's a very good point. And the one thing to point out is that the initial vaccines probably that would be delivered next week will be to hospitals for frontline healthcare workers across a range of disciplines within healthcare, and becoming available to the general public probably more toward the spring. So like there will be time to collect information, right now I know at least that in Johns Hopkins Health System, when we start our process in occupational health, when individuals get the vaccine, they'll have to stay for 30 minutes and be observed, sort of like when you get an allergy shot. And I think what we learn long-term about whether or not people react will determine whether the vaccine has to be given in a medical setting or whether you can go to your CVS or something. So I think those are all the things that need to be followed up on.
I think it's pretty unlikely that it'll have to be, given in a medical setting for everyone, given the fact that there was just so few adverse reactions. I mean, they had people with regular allergies, I think, in the study, but they did not see really any kind of significant increase in allergic reactions in the people who got the vaccine versus the placebo.
Okay, great. And then this is another question. Dr. Phillips is still on. It says, I've tested positive for COVID and I'm on day 12 of my symptoms. The one thing that I'm not hearing about, if you're positive, how critical is it to monitor your oxygen at home with like a home pulse ox? And why has the government not been stressing this as a vital sign to monitor?
Well, the pulse ox is very important because it is one of the indications as far as respiratory distress being one of the symptoms that I mentioned previously about when to pursue emergent care. So you have individuals that are monitoring it. If you're in a position that you're able to do it, that's great. But I think the more important thing is to be aware if you notice a change in your respiratory status and things are starting to become more challenging for you.
Right. So that's very, very, very good point. Because like your symptoms are going to be, if your oxygen saturation has dropped, chances are like you would have symptoms that would prompt you to follow up.
And I would also like to add to that.
Yes. Please.
I also have a pulse oximeter at home that I use on a daily basis as a long hauler. So I do mine daily as well because when my symptoms start happening, my heart rate starts going up and then my breathing starts getting really heavy. So I tend to monitor mine on a daily basis as well.
And if you're in a position to monitor it, as Michael's sharing, I think it's important to recognize if you see below 90%, that's when you should start being concerned. If you want a number.
Right.
Very helpful.
Mine only has gotten as low as 95%. And when it's gotten that low, I have gone into the emergency room post COVID. I've gone to the emergency room since having the infection. I've been to the emergency room 5 times already.
Right. So I think it's better to be safe than sorry, you know, from that standpoint. But again, this is just sort of speaking to what that journey after COVID is like for many people. And I see a comment here from one of our attendees who says, my COVID recovery journey has been moderate to difficult and that their body's still recovering. And this is incredibly serious in that, you know, she's grateful to be on the road to recovery. But I think it's really important to recognize that even that recovery process is a journey for many individuals.
I would add to that, you know, again, individuals that have had it, you know, one of the themes that we've talked about in this discussion is the paucity of data when it comes to people of color with research. And as we mentioned earlier and Mike shared, you know, that post-COVID research is extremely important and it doesn't require any experimental medications. So individuals that have gotten through it, you know, sharing that in a medical way can really be helpful, not alone for just treating people of color with this, but also all individuals that are the quote unquote long haulers.
Yeah, that is so critically important because I know like a lot of the research is being done sort of in the physical medicine and rehabilitation setting. So, you know, they're just wanting to look and see like, you know, what people's physical activity, lung function, cardiac function is like afterwards. And so I think that's going to be, you know, really important because a lot of times after someone has a heart attack or a stroke or something, they go through rehabilitation, for example, and it may be that there needs to be a rehabilitation program for people who are recovering from severe COVID. So, so let's see. The other question I have is the vaccine appropriate for people with autoimmune diseases? Yeah, trying to remember.
I would say HIV, they looked at a bit. They had several hundred people with HIV in the study, did not see a difference. I think that was important between their response and other people's responses. I think it'd probably be something to talk about with your doctor if you have an autoimmune disease, but it's not a specific reason not to get the vaccine at this point, I think according to the FDA, based on anything they know about the vaccine. And one of the questions I saw was, what's in the vaccine? Is it the live virus? And it is not the live virus. It's just a piece of the virus's genetic code made in a way that degrades quickly, but it gets into your cells and your body makes the protein, that one protein, not the full virus. And then your immune system recognizes it and gets ready to destroy the virus when the virus comes in. One other quick thing I can point out was, you know, someone said I have high blood pressure. Is the vaccine safe or should I wait? This vaccine was studied in a lot of people with chronic illness, including high blood pressure, heart disease, and diabetes, and it did very, very well in individuals like that, no problem. High blood pressure puts you at risk for a very severe case of COVID. So I would say that the benefit risk calculation actually works in favor of vaccination for people who have cardiovascular disease or diabetes, given that information, given how sick you can get with COVID and the fact that it was studied in people with those conditions and they did really well with the vaccine.
And if I could just add on to that, I have slightly elevated blood pressure. And so I am on high blood pressure medication. And living in Florida does not help your blood pressure either. And so I would say that, yes, that when they give you the vaccine, they are very thorough in looking at some of your underlying health conditions as a participant. And so I imagine when you receive the vaccine, some may receive it as early as next week. They will be very thorough in looking at that.
That's a really important point. And I would just say, my clinical training is as an endocrinologist. So I spent like 25 years taking care of patients with diabetes. And so, at least at our hospital, some of the more patients who've had the more difficult and long experiences of hospitalization have been those with diabetes, heart disease, obesity. So just to be aware of that. And those are things that are highly prevalent in the African-American community. Let's see. So the next question is, are there any dangers in just getting the first shot and not getting the second shot?
Well, I would say not particularly. I mean, not necessarily any dangers that anybody knows about. You know, there was a pretty good response to the first shot, and Pfizer is going to study whether getting one shot alone is enough. But this study really couldn't answer that question because everyone went ahead and got the second shot too. So you don't know. I think the idea was that they want to use that second shot to really make sure that the immune system is ready for this and that protection lasts a long time. But it will be further studied. We'll know more about that.
So then another question is, how will the vaccine be made accessible? Is it state, local, and is it mandated? And you know, one of the things about an emergency use authorization is that, you know, people have an option. So I can just say at Johns Hopkins Medicine for our employees, you know, we are making it available, but we are not mandating it at this point, just so that people have a chance to get education and information. But Dr. Sharfstein, what would you say about that and the sort of accessibility?
So I would agree with the approach that Hopkins is taking. I think, you know, these vaccine programs, they evolve over time, they become more mature. We learn a lot about vaccines over time. So I think at this moment, it's good to make it available, but it's premature to be thinking about mandating it. Over time, though, you know, if everything seems very much like it is now, and we understand a lot more about it, and obviously there's a lot more available, it may be for certain types of employment that it's considered necessary. For example, some hospitals do mandate flu vaccination because there's so much evidence that getting a vaccine for flu really prevents people from passing it on to their patients. And so it's really a patient safety issue. But, you know, that evidence took some time to evolve. So I think that discussion is going to be in the background for a while, but not front and center. In terms of access, depends what group you're in. So if you work at a hospital, you might hear about it from the hospital because they're getting some of the first doses. If you work at a nursing home, you might hear about it from your employer there. Or if your parent lives in or you live in a nursing home, you might hear about it from the nursing home. But for people who aren't in those initial groups, it probably will be through the state and local health department that you'll understand where it's available. While it's under emergency use authorization, the company just can't go out and sell it. It has to be done through the public health system. Now, that public health system could direct the vaccine to your doctor, could direct the vaccine to your clinic. They could open a special vaccine clinic and tell people, you know, in your age group with whatever types of conditions you might have to come to them. They might show up in your community. So it'll look very different in different parts of the country, how it becomes available. Eventually, when there's tons of vaccine available and it's fully licensed, it'll be just available wherever you look, probably in your doctor's office, hopefully, but it's certainly in pharmacies.
Yeah, but that's a very good point. I think at this early juncture, because we know we probably have people who may be listening outside of Maryland, that a lot of the initial distribution will be driven by like sort of state government. And so, you know, that's why we're sort of staying tuned to what's happening in Maryland with its distribution plan. So let's see. So this is a question, sort of a clinical question. My husband, myself, and son were tested, and I was the only one that tested negative. I did everything I could to isolate myself. And I think this is because COVID is just all over right now, that even when people are practicing really, really good public health practices, this can still happen. So then they were positive, but are now negative. And then this attendee is awaiting her test results. So if she were to test positive, could she reinfect her family? And this is the information I think that we are still trying to understand. You know, if they were very recently infected, you know, it takes a while for like the antibodies to really be built up to be able to test for the antigens. We still don't know how long it's you know, that the people can be immune after they've had an infection. So I don't know, Dr. Phillips, what you say, but I think wearing the mask at home would really be important.
I'm sorry.
Yeah.
I would agree with you. I think because there's so much unknown, who wants to risk it? You know, that's what I would say. I mean, it's not that difficult to wear a mask. Again, with there being so much that we don't know about it, we don't need a Christmas tragedy. I mean, I think everybody, at least I know, you know, has someone that should be here. I mean, we have an Omega Psi Phi call where we our COVID task force, and we meet weekly. And there's a brother that participates. He lost mother, father, and daughter this year to COVID. So, you know, again, do you want to take that chance? So I think, again, I would err on the side of being safe. You know, the other thing is that these tests are not 100%. So you could have tested negative, and it doesn't necessarily mean that you weren't positive, you know, but with all of this unknown, I think I would err, as you said, on the side of being safe.
Yeah, no, I would definitely agree, because depending upon how close your testing is to when your symptoms were, you know, you could be negative initially, but then you could become positive. Usually the recommended testing window is within 3 to 5 days is when you're likely to start being able to detect it. But again, depending upon what the viral load is, really depends upon how long from like symptom onset to when you get tested. So that's why it's also important to keep wearing the mask, stay in another room, you know, use one set of eating, drinking utensils, all of those things. And hopefully your test, your follow-up test is negative, but you know, we just want to give you guidance in case it's not. This is another question related to COVID testing. Is there a higher percentage of false positive results for African Americans who get COVID testing? And I have not heard that there's any difference.
Yeah, I haven't heard any racial, indications with the testing. I think the biggest thing is, you know, looking at, you know, the type of test that you're getting. Certain types, you know, the salivary test has a higher level than the nasal pharyngeal of false rates. So, you know, again, there is that possibility that your test result, even though it may say negative, that you could be positive. So as I said at the top, if you feel you got it, then act like you got it.
Yes, better to err on the side of caution. So this is a really excellent question. Can someone speak to the toll on our mental health as a result of this pandemic? And I think probably many of us can answer that. I'd be interested in hearing what Dr. Phillips has to say, and also maybe Mike, if you're willing to share, because I think there's mental stress on all sides with this. So Dr. Phillips.
Yeah, I think, you know, already mental health issues was a stigma in our community. You know, I think the thing that this virus and pandemic has shown is in many levels how people of color have poorer health metrics, and mental health being one of them. I think that this pandemic, unfortunately, has been the perfect storm with its isolation, with the ways that it's affected how we normally socialize and engage each other. And I think it also has exposed the paucity of resources that we have in our community or don't have in our community as far as how to get help if you're dealing with some mental health issues. I think, as I have talked to people before about being more aware and intentional with your preventive health, we also need to be just as intentional with our mental and spiritual wellness as far as activities that keep us in a safe and healthy space, because everybody that I see, there is a component to how this is affecting them emotionally. I have patients that come into the office, and it's very unfortunate because I might be the one person that they get out of the house to see, and they're really accustomed to that smile, and then or hug rather, that when we normally see each other, and I got to give them the fist pump, the elbow pump, the kid in play, tap the foot. But in any case, the other thing that I think is important is that we have to learn how to pivot. You know, we have been, as you explained earlier, as far as your adjustment with your celebration of Thanksgiving, not that it meant any less than what it normally means, but we had to do it in a different way to still get to that space. So we have to be able to pivot when it comes to things that we have been accustomed to. I'm accustomed to seeing my family regularly, but what we do now, we have Zoom meetings, you know, so I think it's important for all of us to really discover our own personal pivots so that we can still be intentional in maintaining our mental and spiritual health. I think Mike has talked, and I want to hear what he says even more about how trying this has been for him as far as just the mental weight of the path that he's been on.
Yeah, so Mike, I know you mentioned you have PTSD. So for people that may not be familiar, that's post-traumatic stress disorder.
Right.
We typically thought of it as like in combat, but people have it from any traumatic experience. An illness can be one of those things. So Mike, do you want to sort of share that with us?
Yes. So how I figured I developed the PTSD when the virus actually was attacking me full force. The night that it happened, I remember I was so afraid to go to sleep because I was in fear that I wouldn't wake up the next day. And now, as you know, when I go to bed at night now, I still have that fear. Like it, on top of, you know, the post symptoms that go inside with that, it accelerates everything, and it puts a lot of strain on you mentally, where it does affect your sleeping behavior, your mental thoughts, and it's very stressful overall. A lot of people, one thing that I want to say is a lot of people don't talk about the mental aspect of what COVID does, from being in the hospital isolated, as well as post COVID and dealing with the post effects of mental health. I thank, you know, my friends and family for praying for me and calling me and keeping my spirits up, because that made a tremendous difference in my recovery at the hospital and after the hospital. But that's one thing that you know, when I started doing these videos, I stressed that, you know, we need to focus on the mental aspect and help the people that are in the hospitals now fighting to get over that hump, because they need to hear more voices, even if it's just a FaceTime call saying, hey, help me, you know, I'm struggling today. You know, that would help, because you can't physically hold that person's hand. So, you know, just hearing that voice would help them.
Yeah, I think this is really
I just wanted
critical.
to add to what Mike was saying. I'm sorry. I think the other thing that to add on is being aware of the technology. You know, in my office, we have counselors and they do virtual visits. So again, even if you're not able to get into the doctor's office, you can still have your issue addressed. And this doesn't just go for our mental health, but it also speaks to our chronic conditions, which unfortunately have been impacted by this pandemic as well. So again, you know, I have individuals that say, well, my doctor's office is closed because of the pandemic. Diabetes, high blood pressure is not going to go on vacation because of the pandemic. Those conditions still need to be monitored. Those conditions still need to be managed by medication. So the virtual or telehealth, you know, option is something that has developed, and it's something that we need to make sure we take full advantage of.
And can I add, Sharita,
yes.
Dr. Phillips, you make such a great point about technology. Technology is key for our health, but it's also key for our mental health. I grew up in a family where every Thanksgiving, starting with my grandmother, we played a very robust game of Uno. We all have smartphones, so we pulled out our smartphones. I had my best friend in Maryland, my dad down the road from me. We all had 3 separate Uno decks. I delivered a deck to my dad, and we played a really fun game of Uno on Zoom. And so we had a camera on the deck, we had cameras on all of us, and we laughed and we played. And for a moment, it didn't feel like we were apart. I think we can be so creative. I have team musicians and they do little concerts for Pop-Pop. So we have to really look at the ways that we can use our technology and be smart about it and be very intentional. I love the word intentional, and it's a reminder that our mental health takes some planning. So now is a great time to start, you know, shipping those board games or those cards to your loved ones, and then we can all play together and really enjoy each other, but be safe. I just can't, that is just the most important thing. I am so upset about the rise in COVID-19 here in Florida. People are having picnics. I don't see as many masks as I do from my friend sharing in Maryland. It's quite scary. And because it's still warm and sunny, folks have lost their minds down here. And so I am afraid about the spike. Christmas is going to be very scary here. So as much planning as we can do and symposiums like this, it's going to save lives. And I can't tell you how grateful I am for this opportunity today.
Well, thank you. And then that's why we're trying to give everybody the information they need. So we have about 10 more minutes. So we will do as many questions as we can during that. So we'll try to do like speed passing on the questions with like short answers so we can get through some of the other things. So one of the questions is what meds are being used to treat COVID now. So I can take that one because it's fairly short. So you know, right now we have, if you're in the hospital, there are 2 therapies that are being used. Like if you're critically ill in the hospital, and that's remdesivir, and which is an antiviral agent, and dexamethasone, which is an anti-inflammatory agent. Because when you get COVID, you know, it causes your body to have this inflammatory response. So those are the 2 treatments for severely ill patients in the hospital. From the outpatients, say you have COVID, you're not sick enough to be in the hospital, but you have symptoms, then there are 2 what are called monoclonal antibodies that have gotten an FDA emergency use authorization. I think those got their EUAs right before Thanksgiving. And so those are 2 options for people that are having symptoms, but their oxygen saturation has to be above 94%. So the O2 sat cutoff with COVID for when you should be concerned is 94%. So they use that as the cutoff. And right now those are being, at least in the Baltimore area, infused at the Baltimore Convention Center. I don't know if anyone knows about any other from a treatment standpoint, but those are the 2. So there's a lot more research going on to figure out what are some additional, treatments, but right now there are those 2 monoclonal antibody therapies that have emergency use authorizations.
One of the things I would also add, I saw a question in the chat about, other things you can do. I think, again, just being more attentive to your preventive health. If you have medical issues such as obesity, such as high blood pressure, diabetes, you want to get those conditions under control because, again, as it was stated, those conditions could put you at a risk for suffering a little more danger from COVID if you are infected. So again, coming up with a plan to address your overall wellness and how to approach those things that you might have identified as things you need to work on.
So this is an important question from a public health perspective. How should the housing industry safely provide housing to all when people are, from a quarantining perspective, particularly if people don't have, safe options for quarantining. So maybe Dr. Sharfstein can answer that. And there's some things that we've done here in the Baltimore region to have quarantine hotels and other things.
Absolutely. So this is a, question with different levels of housing, but the public health level, it's important that people can safely quarantine to help people find an alternative place to go or safely isolate if they're sick. And so in Baltimore, there's a hotel, the Lord Baltimore Hotel, which is jointly run by the University of Maryland and Hopkins to take people and put them in that a safer place during that period. So that's important. There are also strategies that, for example, senior housing communities can use and assisted living facilities can use. And we just released a free course online for assisted living last week, and next week it's going to be senior housing. I can put the links in the into the chat, but if people who are interested in that area, what can be done within housing, kind of complexes, these courses will be very helpful. They're free and relatively short for people who want to learn more.
All right, great. So this is a question, I think another good one is from one of our attendees who's 71 years old, really has like no health problems or anything. Should they be, should they consider taking the COVID vaccine?
Yes. Yes.
Right. I think the thing is when you get to be, I'm not going to use the word older, I'm going to use mature. When you get to be mature and wise, even, without a lot of health conditions, it's just that things that would normally not set you back might set you back further. And so that's why it's important.
Well, I think age is just one of the biggest risk factors for serious illness and death. It's probably the single biggest risk factor. And so everything else can be perfect, but then people get very seriously ill. And so you just have to realize the risk that's there.
Okay, so there are a lot of questions. Hold on, I'm just looking through. Hold on, I'm just trying to find some that haven't hit on things that we already talked about.
There's a question about a 21-year-old who's very tired, and could that be COVID-19? 21-year-olds who are very, very, very tired in a way that's abnormal should get evaluated by their doctors, because there are a lot of different things that can cause severe exhaustion. Could be COVID. I mean, that's probably on the list these days, but there are other things too.
And maybe, Dr. Watson, I wanted to ask you, just based on some of the discussion we've been having, is there anything you want to add while I am looking through some of the other questions?
No, this discussion, I've been listening attentively and learning from everyone on this panel. So happy to jump in as more questions come up, but nothing to add at this moment.
So there are some, there are a couple of questions in the chat around blood type. And so is there any evidence that one blood type puts you at more risk for COVID than another?
Go ahead. If Dr. Phillips wants to answer, I defer to Dr. Phillips on this one.
No.
Right. Yeah, I was going to say me too. Right. So I just wanted to, sort of put that sort of all in. Okay, let's see. And then there was a question about recovery, how you can support people recovering. I think, just ask them what they need and let them tell you like what help and support that they may need during that recovery process. So, so this is a question. So 83-year-old mom with dementia taking oral chemotherapy. And because of the increased dementia, so she will be moving in with her family. And so they're doing everything to keep her safe. And so, with everybody at home, like what are the best practices for keeping an older family member safe? I think we've covered many of those things. I think this is where you sort of look at the risk benefits in your decision making about, what you will do about, the vaccine. Because if there is someone that's going in and out of the house every day, at least right now, there is just so much COVID around. So it's really important when you're at home around somebody who's older, to wear masks. My parents are 85, so every time I see them, we wear a mask the entire time. Everybody masks, and we've been doing that like the whole pandemic. So I don't know, Dr. Sharfstein, if there's something you want to add. And
what I would add is,
question.
Yeah, there are a bunch of questions about natural treatments that might be worth loping together and answer. But just very quickly, that course that I put in the chat has a whole section on people with dementia and what to do. Even though it's for assisted living, there are a lot of strategies that they talk about that might be helpful in that situation, because it can be hard. People may, if like, for example, if they have memory challenges, they may forget about COVID, may want to hug people, not understand what's going on. And so there are a bunch of different strategies in that course that might be useful.
So, so we are at time for our Q&A. There are some other questions in the chat, and our technology team has saved the chat. So for questions that we did not address, we will follow up and post the answers to those on our website. In addition, we have been recording this, so we will also be posting the recording on our website and find a way to send it to those who registered. So, so one thing I want to say, first of all, I just want to thank our panelists. You all have really enriched our, I've learned a lot from all of you all as well today. And I think that, I hope our audience has as well. This is a really challenging time for, healthcare providers and public health practitioners right now because of everything that's happening. So we really appreciate your time. And to Mike and Maria, thank you so much for your transparency. And I just want to tell everyone that we will be putting a survey into the chat now so that you can complete it. So if you're unable to complete it right now, we'll also be sending it out by email, but you'll only need to complete it once. So if you complete it now, you won't need to complete it again. So I am going to turn it back over to my chapter members. So thank you. I think we're waiting for Pia.
I am here. I'm here taking a few breaths. I'm saying that this was absolutely heartfelt and amazing and absolutely informative. So I am here to, I can feel my heart moving to express my gratitude to all of the impressive panelists. Dr. Jadan Phillips, I felt your energy there as you were jumping in, answering questions. Michael Green, your transparency and just sharing the long hauler experience with us. Dr. Sharfstein as well, getting us clear about the vaccine and also mentioning the natural supplements, because that's often used by our community. Mrs. Maria Roach, thank you so very much. I am honored to have you here on our platform. And Dr. Crystal Watson, we absolutely understand the tears you may have shared when your toddler couldn't spend the holiday with your in-laws and your parents. So we're all feeling that. And last but not least, our fantastic moderator, who happens to be our co-chair. And I'll say this because we here at the Baltimore Alumni Chapter, we really, our intent was, and we use that word intent a lot, our intent was to share fact-based information to our audience. So I hope that the information that you've heard today has helped you to make decisions that make a difference for you and your family, because we are clearly aware that this disease is deadly and is invisible, so we don't know. I've heard several times about masking up. So we definitely make sure that you walk away with that information. You can share with friends and family who were unable to attend. And above all, I send my deepest gratitude and my warm virtual Delta hugs to my entire dedicated and also dynamic Physical and Mental Health Committee. Thank you for that. And we could not be here. And those are their names are listed on the screen. And we could not be here. Now we're in the world of Zoom with our fantastic technology committee, who are able to pivot and make this entire event happen from 12 o'clock until now. So I thank you for that as well. And lastly, we all know it, but let's hear it again. We want to wear the mask. We want to wash our hands. We want to practice social distancing. And once again, thank you and have a pleasant afternoon and a wonderful and blessed holiday season. Thank you.
Thank you.
Thanks again, everyone.